This is an audiovisual presentation on the topic of pneumatic tourniquets. In this video, we'll explore the use of tourniquets in foot surgery. But before we start talking about its application and safe use, we need to understand what a tourniquet is and how it evolved. The tourniquet is a device used to stop or reduce blood to an extremity. This can greatly improve the operating field, allowing better visualization of anatomical structures and limit intraoperative blood loss. The earliest known usage of tourniquet dates back to 199 BC to 500 AD. It was used by the Romans to control bleeding, especially during amputation. These were narrow straps made of bronze, using only leather for comfort. The goal was to save life without regard for the limb. The elementary tourniquet devices used by the Greeks and the Romans remained virtually unchanged until 1718, when French surgeon Jean-Louis Petit created a screw device to occlude blood flow at the surgical site. He coined the term tourniquet from the French verb tourner, to turn. This turning mechanism allowed for more precise control over the amount of pressure. Nowadays, tourniquets are electronically controlled pneumatic devices with accurate pressure control, timing, and alarms to improve their safety. Tourniquets are most frequently placed on the upper arm, thigh, or ankle, therefore lending themselves to a broad spectrum of elective and emergency surgery on the upper and lower limb. They can also be utilized for intravenous anesthesia, such as the Pierce block. Tourniquets facilitate surgery on the extremities by decreasing perioperative blood loss and provide a bloodless surgical field. This in turn reduces the length of operation and complications caused by poor surgical vision. The tourniquet should be first deflated and smoothed out, and adequate padding should be placed around the limb before application of the tourniquet. This helps reduce wrinkling, pinching, and shearing of the soft tissues. A circumferential adhesive-packed plastic drape applied just distal to the tourniquet can help prevent surgical cleaning solution soaking beneath the tourniquet, which would lead to iatrogenic chemical burns. Wider cuffs provide better transmission of tissue compression, and lower cuff pressures are required to compress the artery, reducing the risk of pressure-related complications such as soft tissue, muscle, and nerve injury. The cuff should not directly overlie bony prominences like the malleoli, as there is a risk of direct nerve compression. It is recommended that the edge of the tourniquet should be at least 2 cm proximal to the malleoli. The length of the cuff is dependent on the patient's limb size, but it should be the minimum that allows the inflatable portion of the cuff to completely encircle the limb at the location and fully engage the fasteners. Selecting a cuff that is too long, resulting in excessive overlap, may be difficult to apply snugly and may be less stable, causing the cuff to move distally or shift on the patient's limb. Both problems may prevent occlusion of arterial blood flow at normal cuff pressures, lead to loss of occlusion during the procedure, and lead to skin injury. Selecting a cuff that is too short, resulting in too little overlap of the inflatable bladder portion of the cuff, produces uneven distribution of pressure and can lead to loosening of the cuff or an inability to sustain occlusion. The limb should be exsanguinated by elevating the leg and using an S-march bandage for emptying the blood vessels from the distal end to the proximal end prior to tourniquet inflation. Safe limits for time and pressure are controversial, but the shortest possible time at the lowest pressure is safest. No strict guidelines exist, in part because each patient is different and what is safe for one limb is not necessarily safe for another. Surgeons generally practice fixed inflation pressures, typically 300 mm of mercury for the lower limb, or fixed amount of pressure above systolic arterial pressure, typically 100 mm of mercury. If the patient is obese, this will usually need to be higher. Up to 50 mm of mercury can be added. However, these practices do not take into account patient-specific variables, such as the age. It has been shown that younger age is an independent predictor of neurological injury after prolonged tourniquet times due to younger patients having lower systolic pressures, meaning there is a larger difference between tourniquet inflation pressure and arterial pressure, leading to excessive compression. Tourniquet inflation can also be based on limb occlusion pressure, using a Doppler technique to confirm the absence of arterial pulse to determine the minimum inflation pressure. Tourniquets should be kept inflated for the minimum length of time possible to minimize risks to the patient. There is a strong correlation of nerve injury with prolonged total tourniquet time, with a threefold increase in risk of neurological complications for each 30-minute increase in tourniquet inflation. Most recommendations in the literature suggest a maximum tourniquet time of 1.5 to 2 hours in a healthy adult, which corresponds to the point at which muscle ATP stores are depleted. Within the literature, most authors advise a maximum tourniquet of 2 hours, and if longer than this is required, the tourniquet should be deflated for 10 minutes after every 30 minutes. This deflation interval allows for temporary reperfusion of the limb, assisting in repletion of the ATP depleted during the period of ischemia. Following inflation of the tourniquet, there is a decrease in tissue oxygen and an increase in tissue carbon dioxide and lactic acid. Intracellular energy stores of ATP are exhausted after 2 hours. In terms of cardiovascular effects, limb exsanguination and tourniquet inflation increase blood volume up to 15% and systemic vascular resistance. This is because blood is being displaced from the distal vasculature, creating a surge in overall blood volume and central venous pressure. Heart rate, systolic and diastolic pressure may also increase after 30 to 60 minutes of tourniquet inflation due to ischemia and tourniquet pain. Tourniquet inflation is associated with a hypercoagulable state due to increased platelet aggregation and stimulation of coagulation factors caused by tissue damage. However, there is also a period of reduced coagulation produced immediately after deflation of the tourniquet due to the release of plasminogen. This transient fibrinolysis is the main contributor to post-tourniquet bleeding. There are no absolute contraindications to tourniquet application, but adequate care should be taken in the following group of patients: severe peripheral vascular disease, including Raynaud's disease and DVT. Patients with peripheral vascular disease have decreased vessel wall compliance and already compromised tissue perfusion, making tourniquet use less effective and predisposing to further ischemic damage. Venous thromboembolism is also listed within the literature as a potential complication of tourniquet use. Some authors suggest tourniquet is contraindicated in patients at high risk of DVT due to a number of case reports of pulmonary embolism associated with tourniquet use. Tourniquets should be avoided where possible in sickle cell disease. The main pathology in sickle cell disease is an abnormal hemoglobin molecule, hemoglobin S, which has a predisposition to clump together and cause the red blood cell to deform into its characteristic sickle shape. This abnormal shape of the red cells prevents them from deforming as they pass through narrow capillaries, leading to obstruction of microvasculature. A sickling crisis is triggered under conditions such as circulatory stasis, acidosis, and hypoxia, the same conditions caused by tourniquets. Patients with poor cardiac reserve may not tolerate the sudden increase in blood volume following limb exsanguination and tourniquet inflation. Similarly, tourniquet deflation is a critical stage because it causes a sudden drop in central venous pressure and mean arterial pressures. Limbs with severe infection are a relative contraindication due to the potential for systemic spread. Hypertension requires a higher amount of pressure to overcome blood flow. In extreme cases, this can predispose to local complications such as nerve and muscle injury. Poor skin condition of the limb and diabetic neuropathic patients are also relative contraindications due to the increased risk of tourniquet-induced damage. Complications of tourniquet use are fortunately very rare. Complications increase as tourniquet time increases. Nerve injuries are the most common complication. Injuries range from simple paresthesia to paralysis. Pressure and duration of nerve ischemia are the two main factors. Odinson and Vincent conducted one of the largest studies on tourniquet use and its possible complications over a 2-year period. Out of 63,484 operations done with the tourniquet, only 18 complications caused by the tourniquet were reported. Most of the complications occurred after the tourniquet had been inflated for less than 2 hours at a pressure of 300 millimeters of mercury or less, and resolved spontaneously within 6 months of surgery. 2 of the major complications occurred with tourniquet times of 130 and 180 minutes, and with pressures of 250 and 300 millimeters of mercury, suggesting that ischemia time is an important factor for major or permanent complications. There were 3 cases of skin complications. The most frequent cause of chemical burn is seepage of antiseptic solution into the padding beneath the cuff. Muscles are susceptible to prolonged ischemia, more so than nerves, and muscle damage becomes evident after 60 minutes of tourniquet inflation, with progressive hypoxia, acidosis, and cooling in the occluded limb. Tissue edema develops, and after deflation, the return of circulation leads to the development of reperfusion injury. Intraoperative bleeding may occur due to an under-pressurized cuff, insufficient exsanguination, improper cuff selection, loosely applied cuff, or calcified vessels. Thank you so much for listening. Please like, comment, and subscribe.